Hola, ¿cómo están todos? Bienvenidos a Un Café con el Experto, una edición más. En este episodio estamos grabando desde Citic 2025 y bueno, hoy tengo el placer de estar acompañado de uno de los intervencionistas más conocidos y más importantes en el ámbito de TAVI, de intervencionismo estructural y de intervencionismo de válvulas, que es Didier Tchetche. Para mí va a ser un placer entrevistarlo hoy y le agradezco muchísimo que esté con nosotros aquí en México, compartiendo todo lo que nos vino a compartir y sin duda participando activamente con tantas discusiones. Didier, thank you for being here. It is my great pleasure to have you here. Thank you for accepting to come to Mexico. Is it your first time in Mexico?
Yeah, very first time. Very first time. And it was a blast. So I didn't imagine such an energy, positive energy here. So I'm really...
thank you so much.
It's a very nice meeting.
It's did you imagine how was it? No.
I have no clue about the size of the meeting.
Oh, okay.
And the attendance is great, in fact. A lot of energy, and I like the interaction.
Yes.
So it reminds me about the PCR spirit. You know that we are really fond of exchange and interaction, and we get that here. So that's great.
For sure. Well, it is our pleasure that to hear this in your lips, but it is also a pleasure that you accepted to do this podcast because we want to know a little bit more about Didier behind the Dr. Didier Tchetche. Okay, so tell me a little bit about where you were born, and then how was your medical education? Did you go out from France or no? And now, how did you move to Toulouse? Why? A little bit about that.
Okay. So so I was born in Ivory Coast, and I came to France when I was 5 years old with my parents, just to get a better education and a better lifestyle in general. So I grew up in Paris, and I had the great privilege during my medical school to be one of the fellows of Alec Vahanian. Alec was the Pope of valvular heart disease with a lot of experience in rheumatic disease on the mitral side, as well as aortic stenosis. And in fact, it's funny because he was a co-fellow with Alain Cribier. So they shared the same passion for valvular heart disease.
Yes.
So that generated a lot of interest from me towards that aspect of cardiology, structural heart disease. And then I moved to Toulouse for a fellowship. It was like 20 years ago. And I had the privilege to meet Jean Fajadet and Jean Marco at that time.
Oh, yeah.
And after completing my medical residency and in Paris, I moved back to Toulouse to become a partner. So I was very fortunate to meet these people.
Yes. Now that you touched that topic, how is it to be that close to Jean Fajadet and Jean Marco, because they are big gentlemen of the interventional cardiology and visionaries of this film?
Yeah, we owe them a lot, and you can imagine how impactful it was to work with them. Jean Marco, as you said, was a visionary person. PCR is due to him and Jean Fajadet. And Jean Fajadet was one of the most skilled operators that I met in my life. Okay. So being first a fellow, I could train with him and learn a bit of his techniques, some of his techniques, and then becoming a partner, if it was all about maturing my experience, getting more skilled at performing PCI, because I started with chronic total occlusions.
Really? You are the CTO operator?
Yeah, I was a CTO operator in the past.
I didn't know that. I think that probably nobody knows that. Well,
PCI is the background. And then I moved to had the chance to be there once TAVI started to become the key procedure for the future.
Yeah.
So I built the TAVI program in Toulouse. And then lately I was joined by Nicolas, and it became a very, very fruitful and very, very expanded program.
Yes, you have one, if not the most, the biggest program. I don't know, because you have how many TAVIs per year do you have?
1,200 per year.
1,200 per year. So it is like 10 per day.
It could be up to 10 per day.
10 per
day.
Day.
So we mix it with we merge it with the coronary program, so it's kind of routine, and that's the key.
Doing or performing up to 7 or 10 TAVIs per day needs to have a very efficient program of TAVI. And I saw a video. I have to say that I am biased because I know how you work, because you showed us a video like 4 or 5 years ago of how to do a very good program, very efficient program of TAVI. And it is not one or two people involved. It is a lot of people involved in that.
Exactly.
But you do it very, very well. So how do you what are the tips and tricks that you could share with us about how to build a very, very efficient program of TAVI?
I think there are different levels. The first one is the overall organization. So you need to think about the pathway as it could be improved depending on your local practice. So it went through involving the hospital administration, getting 2 TAVI coordinators, because they are really key to organize everything, to talk to the patient, to explain everything. And then we all know how to optimize the procedure. It's more contemporary now with the echo-guided puncture, all this stuff. And we build the post-operative care to make sure that we could early discharge safely the patient. So organization was key, involving all the key stakeholders of the hospital and the nurses, the anesthesiologists, everyone.
When you say early discharge, you mean the next day discharge or the same day?
No, next day or within 2 days. Within 2 days seems reasonable in France.
Okay, but they are like very minimal invasive procedures.
Yeah.
So they could be like seated in the room for the same day.
Yeah.
And probably just what's the major inconvenience to discharge the patients the same day? It is the conduct disturbances, or
yeah,
what?
I would say the conduction disturbance. You're right. Maybe it's the major obstacle.
Yeah.
And still, the patients are elderly patients, so for them, they like to stay overnight in the hospital, and I don't see any reason not to do so, because it's more comfortable for them. They stay overnight and then they go the next day or 2 days afterwards, and it's better.
So in terms of deciding the device that you are or the tab the THV that you are using, how do you decide? Because it is a lot of patients, so who takes part of the decision of what's the best device? Is it the operator? Is it or how do you measure the CT? Are you involved in that, or how's the group? I can here in Mexico we have to do everything because we don't have that volume of patients, and we are able to do that. But I can imagine that if you have 10 patients per day, probably you could give a second look of everything, but probably the one that is measuring everything, it is part of your team, but it is different.
Exactly. It's true that we have trained fellows to become extremely efficient at doing the planning with the CT. So we have a second look just to make sure that everything is fine prior to the procedure, and we decide on site. Every nurse is trained for any single device, so they can prep every kind of device.
They can do everything. Okay.
So once we have decided on the device type and size, they prep it. So it's all about understanding the risks of the procedure for the patient. If there is a risk of coronary obstruction, annular rupture, high AV block, a need for a coronary cannulation, and then we adapt to the type. We select the type of device and the depth of implant, the size, everything is done the same day. But it's really an integrative approach.
And when you have concomitant coronary disease, how do you set? I mean, do you do in the same procedure? Do you do in two different procedures? And if so, what do you do first?
Yeah. So there is. I would say that there is no dogma. It's all about tailoring to the patient. If there is angina and the patient is presenting for an acute coronary syndrome, we're going to treat the coronary artery disease first, wait for a couple of weeks, 3 weeks, and then go for the AS treatment. If AS is first, we're going to focus on AS. And I have to say that we are not reluctant to perform the PCI after the TAVI. So we need to work on the commissural alignment, selecting the proper device, the proper depth, just to make sure that we're going to make it easy to get access to the coronary artery. So it's still debated. I'm sure that you do differently, but it's...
Well, yeah, it depends on the patient here also. But we do all. I don't know if you are the one responsible to do the coronary, the coronary treatment after that. Because you are with that high volume. I think you're not doing any coronary treatment But in these places, you do.
Yeah, we do.
Okay,
We
go
do. We
ahead,
do.
go ahead.
We do. If there is PCI that is required, we do it. I do it afterwards, and it's because to my opinion, if we think about the future, uh, I don't imagine that there will be only operators dedicated to TAVI.
Yeah.
You need a kind of PCI background because you need to be able to rescue a coronary issue during the procedure. So I guess whoever wants to embark into a TAVI program needs to acquire this PCI skill, or at least the basic stuff.
And what do you think, or what do you, where does the TAVI go? So I think right now we have a lot of knowledge about TAVI, but we still lack of something. So what's the future of the TAVI in your eyes, in your perspective? What do you think is going to be the TAVI in 2030? How do you see it?
So first, I see an expansion of the volumes. We're going to be overwhelmed by the number of cases. So we need to be organized and we need training. So the meeting such as Citic, RioVav, London Vav are very important. So there will be a greater need for education. So the future, I see it through education. Education towards the therapy, sizing, selection of the devices, and tailoring the therapy to the patient. In terms of indication, I guess bicuspid, we're going to learn more about that. How to maybe there will be a need for a dedicated device for bicuspid because it's more complex. The indications have already expanded. We are treating or allowed to treat asymptomatic patients in some specific situations. Pure aortic regurgitation, bicuspid, we already do. We need to improve. And the level of what I anticipate in the future is the type of operator. There may be more hybrid specialists, operators able to do some surgical procedures. You could be a cardiologist with a surgical skill to expose the common femoral artery to get rid, to solve some vascular complications, the minimal ones. And you could be a surgeon performing the structural heart disease interventions, but with enough skills at treating coronary arteries percutaneously. So these hybrid specialists in the future are going to be the way.
That's true. Maybe that's going to be the way we're going to be formed as doctors. And last but not least, Didier, I've heard that you say in one session that we were previously, that the age is different or should be different in different latitudes because it impacts, and it is real. It is real because I think that we couldn't translate the survival rates in one country to another. But how do you think we should manage that? Because nowadays having a 55 years old patient at France is going to be rejected for TAVI. Probably it's going to
be surgery.
But in Africa, it's going to be different.
It could be.
So how do you put the age in terms of?
So I think it's you need to match once we get a better understanding of the true durability of the TAVI platforms. I guess it's going to be around 10. I have had patients above 10 years of durability, like 14 years after a Evolut implantation, a core valve.
Okay.
So that's crazy. I think that these devices are durable. So we need to understand what is going to be the average durability, match it with the life expectancy in our region of the globe. And keep in mind that if we go for TAVI first, if the second procedure is likely not to be a surgical one because it's more complex to do an explant. So we have to make sure that we can do a redo TAVI. So that is going to be the way I will approach, depending on the region of the globe where I'm working.
Thank you, Didier, for all this
thank you for having
tips and tricks that you shared with us. Last comments from you about Citic, about Mexico, about everything.
Citic es fantástico. Es un congreso maravilloso.
Gracias, Tchetche. Muchas gracias. Es un placer tenerte aquí. Muchas gracias.
Muchas gracias.
De verdad. Gracias a ustedes por escucharnos. Espero que les haya gustado. Espero que hayamos coincidido en muchos de los puntos en los que Didier nos compartió, que yo creo que es uno de los operadores más expertos de TAVI en el mundo. El volumen que él tiene le permite ser toda una autoridad en el área, y obviamente todos los comentarios y tips que nos pueda decir sin duda tienen un valor incalculable. Muchísimas gracias. Les recuerdo que activen las notificaciones, que nos den like si es que quieren. Y bueno, nos vemos en el siguiente episodio de Un Café con el Experto en Citic. Muchas gracias. Thank you.
Thank you.
Merci beaucoup.
Merci.